Hello, and welcome to the Outcome Measures and Psychometric Properties project by Katie Boydston, myself, Jake Kane, Jared Joel, and Macy Replogle. This is a project on the McGill Pain Questionnaire and the Functional Gait Assessment tests. For the first part of this project, we're going to talk about the McGill Pain Questionnaire. The McGill Pain Questionnaire is it's a self-reported measure that takes into account what the patient reports themselves. It is a quantitative description of their pain and properties of their pain. When filling out this questionnaire, the patient will have some questions such as descriptors of the pain, which they'll describe it in one word, components of the pain, how it affects them. That's going to be in 2 words, an evaluation of the pain itself, which is 1 word, how it affects them, so some sort of things like that, how they would describe it, and miscellaneous category where they choose a word as well to describe it. This is generally just to give a good idea of what does this pain do to them, and gives a full description of it to give us as clear a picture as possible of how we can proceed. The McGill Pain Questionnaire isn't specific to any sort of population. There's no real target as it works for everybody. It'll work for any sort of condition, musculoskeletal conditions, chronic pain, cancer, back pain, arthritic pain, and any other sort of pain that you can think of. There is no age range for it, as it's very comprehensive and works for anybody that above the age of 13 that can answer for themselves. And so it works all the way from adolescents all the way through elderly adults. This assessment specifically covers pain by the patient and descriptors of how they experience it. In the ICF domain, the McGill Pain Questionnaire falls into the category of body function. This is a very easy test to administer. It doesn't require any sort of materials other than the questionnaire itself to hand to the patient. It requires about 30 minutes to fill out, and this varies according to how fast they fill it out. There's no training needed. You're just handing them the paper, and there's no real cost to it whatsoever. It's very easy to administer overall. As far as scoring the assessment is concerned, there are descriptive words throughout the assessment that they choose, and each of these words has a specific number assigned to it or a value. And after the patient has completed filling out the form, they'll add up all of these values that they marked and get a total. And the totals will range from 0 to 78, 0 being no pain whatsoever, to 78 being completely severe pain that they can't handle. So it allows for a wide range of different scoring, so we can really get a good idea of what the patient needs and how serious their pain really is. There were very few detailed statistics listed for the actual psychometric properties of this test, but the ones listed are for non-specific patient populations. The validity of the McGill Pain Questionnaire showed that there were high levels of agreement observed despite differences in cultural, socioeconomic, and education levels among all patients. So it seems to be something that can be very accurate, especially because it's a self-reported measure, and we're most concerned with how the patient feels primarily. Here you can find a link to the full McGill Pain Questionnaire. It's a PDF of just a blank version of it. We are now going to move to the section of this project concerning the functional gait assessment. The purpose of this test will be to assess an individual's postural stability during walking and their ability to perform multiple different motor tasks while walking. To set up this test, a therapist will measure and mark a 20-foot walkway with a marker at the beginning that is 12 inches in width or 1 foot, and a marker at the end that is 12 inches in width or 1 foot. That is, again, 20 feet from the first mark. The patient will walk this walkway in 10 different ways while having their gait assessed by the therapist. Each of the 10 different walks is graded on a scale of 0 to 3 and is scored individually. They each have their own criteria that the therapist scores themselves. And each score will be added together by the therapist to get a total score out of a maximum of 30. The first out of the 10 assessments will be a surface that is level with the ground or level with the gait of the patient themselves. It's simply the therapist instructs the patient to walk at a normal speed from the first mark to the second mark, which is 20 feet away. The second of the 10 assessments is the change in gait speed assessment, where it begins similar to the first one, where the therapist instructs the patient to begin walking at their normal pace. But this one's different, where the therapist says go at the 5-foot mark once the patient reaches 5 feet. The patient will begin walking as fast as they possibly can. And then when the therapist says slow at the 10-foot mark, so after 5 feet of walking quickly, the patient will walk as slow as they can until the 15-foot mark, where it'll stop. The third assessment is gait with horizontal head turns. So similar to the first two, the therapist will instruct the patient to begin walking at a normal pace. After 3 steps, the patient will turn their head and look to the right. After 3 more steps, the patient will turn their head and look to the left. This will be instructed by the therapist as they go. It'll be good to walk next to the patient and have them turn at your command. It'll be easier for them. The patient will continue this pattern walking straight while alternating left and right every 3 steps until they have completed 2 repetitions in each direction. So 2 while facing right of 3 steps apiece and 2 while facing left at 3 steps apiece. The fourth assessment is gait with vertical head turns. So a sort of nod of the head every 3 steps. It's similar, very, very similar to the third step with horizontal, but this one's just with a nod motion. So they're walking at their normal pace. After 3 steps, the patient will tip their head up and look up. After 3 more steps, patient will tip their head and look down. And they will continue doing this until they've completed 2 repetitions of up looking and 2 repetitions of down looking for 3 steps apiece. For the fifth assessment, this is the gait and pivot turn. The therapist will instruct the patient to walk at their normal pace. When the therapist tells the patient to turn and stop, the patient will turn as quickly as they can to face the opposite direction and stop. This is not at a set point, so the patient will not be knowing when they will turn around, but will be as soon as the therapist says to do this. So they have to react to the therapist saying this, turning and stopping and facing the opposite direction. For the sixth assessment, the patient will step over an obstacle that's placed there by the therapist. The therapist will place either 1 shoebox or 2 stacked shoeboxes that they've taped together in the patient's path during the 20-foot gait. The therapist will instruct the patient to begin walking at the normal pace with no head turns or any sort of a thing, and they will have to step over the shoebox or the obstacle that's placed there, not around it, and keep walking. So they will have to overcome an obstacle rather than avoid the obstacle. The seventh of the 10 assessments will be gait with a narrow base of support. So the therapist is instructing the patient to walk with their arms folded across their chest rather than on their sides, and their feet aligned heel to toe. So if the right foot is in front, it's the right heel touching the left toe, and walking in tandem with them through 12 feet. The therapist will count the number of steps the patient was able to take in a straight line successfully for a maximum of 10 steps. The eighth assessment will have the patient walking with their eyes completely closed. So the therapist will instruct the patient to walk at their normal speed from the first mark to the next with their eyes completely closed. So they will have to assess their balance as they go from one marker, the beginning of the 20 feet, to the marker at the end of the 20 feet. The ninth assessment simply has the patient ambulating backwards to a spot determined by the therapist, not necessarily at the end of the 20 feet. They will walk backwards until the patient tells them to stop. The 10th assessment forgoes the 20-foot marker for the actual gait for the first 9 assessments, and the therapist instructs the patient to walk up a set of stairs as they would at home. And they'll go up the stairs, and at the top of the stairs, they'll be instructed to turn around and walk down the stairs. The video linked here on YouTube gives a thorough presentation on the entire test as I've already described it. And this next one at Physio U provides a brief summary with links to view each section of the test. So each of the 10 parts of the test you can see here on this link. So this is a very helpful couple of links that can help give a visual to what I've been describing. The target population for this test is not specific, and it works for essentially all populations. And it's just a very good way to measure gait for Parkinson's disease, stroke patients, vestibular disorders that affect balance, and all older adults who are at the most risk for falls in everyday life. It works from any adult population from 18 to 65 plus. The functional gait assessment tests balance in the vestibular area if it's coming from a vestibular problem, a non-vestibular problem, and assesses gait in all forms. The domain for this test, according to the ICF model, is in the activity category as it is a functional assessment. As far as administering this test to any sort of patient, it'll be a length of anywhere from 5 to 20 minutes, depending on how quickly the patient can complete and how quickly you can assess. There needs to be no sort of training to administer as you're following a sort of template to complete this. You will need a stopwatch to measure how long the patient takes to do each of these sections, each of the 10, a measuring device to mark off the walking area of at least 20 feet long and 12 inches or 1 foot in width, and a set of steps specifically for the 10th part of the assessment, which is the stair-stepping one. And it'll need to be at least 7 3/4 or 9 to 9 inches high with bilateral rails for the patient to hold on either side. For scoring the test, each of the 10 sections of the test is scored on a scale from 0 to 3, 0 being severe impairment, 3 being normal ambulation, completely normal gait. Each section scoring is determined by a detailed set of criteria for each specific score. But the general idea is 0 is a severe impairment, can't even do it. 1 being a moderate impairment, they can do it with a little bit of difficulty to a moderate amount of difficulty. 2 being a mild impairment without much difficulty, and 3 being completely normal, as I stated before. These statistics were documented for individuals with balance and vestibular issues. It had a minimal detectable change of 6.0, and a minimal detectable change is the amount of change required to distinguish a true performance change from a change due to measurement error. So this sort of measurement accounts for measurement error among testers. It has a sensitivity of 50% for balance disorders and 53% for vestibular disorders. It has a specificity of 70% for balance disorders and 63% for vestibular disorders. It has a CE, or a ceiling effect, of 25%, and it has an inter-rater reliability for vestibular orders of 0.86, indicating a strong to excellent inter-rater reliability. It has an intra-rater reliability for vestibular orders of 0.74, indicating a strong intra-rater reliability. It is a 79% or 0.79 internal consistency. And evidence for construct validity was determined by using a Spearman correlation between FGA and other measures, such as the 10-meter walk test, the BBS, the 6-minute walk test, and stroke impact scale. The standardized response mean for people with balance or vestibular disorders was 1.25, which indicates that FGA is responsive to change. SRM equals 1.25, which is greater than 1.0 standard to conclude responsive. Here you can find a list of references that our group used for information on both assessments.